Hello doctors, Dr. Anatomy here. In this video, we are going to discuss about the brainstem. So what are the structures are present in the brainstem? Brainstem is made up of midbrain, pons, and medulla. Okay, brainstem it connects the spinal cord to the cerebrum. The first we are going to discuss about the medulla oblongata. Here is the structure. Below the pons, medulla oblongata is here. So first we will discuss about its anatomy and its clinical anatomy, clinical orientation of the medulla oblongata. Okay, medulla oblongata it is the lowest part of the brainstem. Okay, Mm, extending it extends from the pons, lower border of the pons to first cervical nerve from the spinal cord. Okay, lies in the anterior part of the posterior cranial fossa down to the it extends up to the foramen magnum. Okay, the first detailed structure anatomy will discuss about this medulla oblongata. Okay, so medulla oblongata it is divided by a line structure called as anterior and posteriorly anterior median fissure. Okay, divided into right and left halves. Okay, this is your right half and this is your left half. Okay, by this line name is called as anterior median fissure. Anterior median fissure. Okay, right and left half is divided by anterior median fissure. Okay, this is right and left half anterior median fissure, and further it is divided into anterior and lateral. Okay, sees your anterior and lateral by anterior lateral sulci. Okay, so anterior part, this is your anterior part, this is your lateral part. Okay, and in between it has a longitudinal elevation. For example, this is the longitudinal elevation. Okay, it's named it as pyramid. Name it as pyramid. Okay, the pyramid what I am going to discuss is below the, as we had discussed earlier in the tracks, you will see decussation fibers are crossing in the pyramids. This is known as pyramidal decussation. It occurs in the lower part of the medulla. Okay, and laterally we are having a elevation known as olive. This structure is known as olive. Okay, this structure is olive. It is formed by inferior olivary nucleus. Inferior olivary nucleus. Okay, So here it is foramen cecum. Okay, here it is foramen cecum. So the nerves from the is anterolateral sulci. Nerve rootlets are passing. These nerve rootlets are your hypoglossal nerve. Hypoglossal nerve rootlets from anterolateral sulci. Okay. So from posterolateral sulci, accessory nerves, cranial roots of accessory nerve. Okay. Accessory nerve rootlets passes from posterolateral sulci. Okay. And the other nerve we see here is glossopharyngeal nerve. The other nerve we are seeing here is glossopharyngeal nerve. Okay. Above that, we are having vestibulocochlear nerve. This is your vestibulocochlear nerve. So here we had discussed everything about the medulla oblongata. See, pyramid. This is your pyramid. This is the olive formed by inferior olivary nucleus. So these are the nerve rootlets of hypoglossal nerve. Okay. So the next we are going to discuss about its blood supply. Blood supply. Two arteries we are going to remember. What are they? Anterior spinal artery, anterior spinal artery, and posterior inferior, posterior inferior cerebellar artery. Posterior inferior cerebellar artery. Anterior spinal artery supplies medial part of the medulla oblongata. Okay. Posterior inferior cerebellar artery supplies posterior and lateral part of the medulla oblongata. Okay. So remembering this blood supply and arteries, which part they are supplying, so clinically correlate this, we are having, so clinical anatomy of this medulla oblongata, we are having two syndromes, named it as medial medullary syndrome and lateral medullary syndrome. Medial medullary syndrome or Dejerine is also known as Dejerine syndrome. It itself says medial part of the, for example, this is the medulla, this is the medial part of the medulla oblongata is damaged. What is its blood supply? So clinical anatomy, medial part of the medulla oblongata is supplied by anterior spinal artery. So the cause of medial medullary syndrome, it is blockage of, it is because of blockage of anterior spinal artery. So clinically we are going to correlate this anatomy right now here. So I had discussed in the anatomy part, like medial part of the medulla oblongata, which are the structures are present. So I had told you longitudinal elevation between the medulla oblongata, we are having pyramids. So pyramid has its pyramidal tracts. So what you will see here, paralysis. So pyramidal tracts, paralysis you will be seeing here. Okay. So paralysis contralateral. It's contralateral because pyramidal tracts are caused. Okay. The second medial lemniscus is damaged. Medial lemniscus loss of sense and vibrations. Sense of vibration and position. Sense of vibration and position sense is lost because of medial lemniscus is damaged. Okay. The third injury to the 12th cranial nerve. 12th cranial nerve, paralysis of muscles of the tongue, contralateral or ipsilateral. It is ipsilateral. Okay. The next, I will show you the image of medial, medullary, and degenerative syndrome. What are the structures are coming in between? What is going on? So features we can see here: paralysis is contralateral, vibration and position because of medial lemniscus is damaged, paralysis of muscles of the tongue because of the 12th cranial nerve. Okay. So the next we are going to discuss most important thing, lateral medullary or Wallenburg syndrome. So lateral medullary, name itself it is telling lateral part of the medulla is damaged. So lateral part of the medulla is damaged means which artery is going to block? Posterior, inferior, cerebellar artery. Okay. Yes, blockage of posterior, inferior, cerebellar artery. Okay. What are its clinical features of lateral medullary and Wallenberg syndrome? So, ipsilateral paralysis. Here we will see ipsilateral paralysis of most of the muscles of the soft palate. Ipsilateral paralysis of the muscles of soft palate, pharynx, and larynx. Why? Here we are having nucleus ambiguous in it. So nucleus ambiguous, it gives rise to 9th, 10th and 11th cranial nerve. The second clinical feature here, paralysis of the muscle, the first clinical feature, and the second clinical feature, it is loss of pain and temperature. Loss of pain and temperature on the face. It is ipsilateral. Okay. The third clinical feature will be loss of pain and temperature contralateral. Okay. Opposite side of the body. Why? Because of the spinothalamic tracts. As we have discussed in medulla oblongata structure. So laterally, okay, spinothalamic tract have two types: lateral spinothalamic and anterior spinothalamic tracts. Okay. So vestibular nerve supply is there from posterolateral nucleus. I had discussed in the anatomy. You will be having giddiness because of this. Giddiness and loss of equilibrium, and ataxia of the limbs. Why? Inferior cerebellar peduncle is damaged and spinocerebellar tracts are damaged. And sixth clinical feature of lateral medullary syndrome, it is Horner syndrome. Why? Because the sympathetic fibers passing from the hypothalamus. So sympathetic fiber passing from the hypothalamus, sympathetic fibers passing from the hypothalamus to lateral horn of the spinal cord, it is gone in the medulla oblongata. Okay. So that's why it causes Horner syndrome. Horner syndrome means ptosis, meiosis, anhydrosis, and anophthalmos. Okay. So here is a Wallenburg picture. As an image, I want to discuss you. See, this guy is having same side. For example, this is the same side. Okay, same side of face. What is gone? Temperature and pain is gone. Okay, same side temperature and pain is gone. Contralateral side of his body, pain and temperature is gone. Okay, you can see equilibrium is not there, loss of equilibrium, ataxia in the limbs. Okay, and also in the mouth you will see paralysis. Okay, paralysis of palate, pharynx, and larynx. He will be have difficulty in swallowing. Okay, and the next you will see anhydrosis, ptosis, anhydrosis, anophthalmos, and meiosis. This is your Wallenburg. Wallenburg is nothing but lateral medullary syndrome caused by posterior inferior cerebellar artery. Because of this artery blockage, medial medullary syndrome or Wallenburg syndrome we get. So here is a image of the medulla oblongata. Medially, what are the structures are present? So this is your medial medullary syndrome. This is your lateral medullary syndrome. So what are the structures are present here? We can see medial lemniscus. Because of this pain and okay, sorry, medial lemniscus, because of this sense of vibrations are gone and position sense is gone. Okay, because of this, and pyramidal tracts, because of this you will see paralysis, that is also contralateral. About the detailed video of the tracts I had discussed in the earlier video regarding the tracts of the pyramidal tracts. Go through it, you will, why it is contralateral you will understand, because these fibers are crossing. Okay, in the medulla oblongata it itself it is crossing. Okay, in medial medullary syndrome, medial lemniscus is gone, pyramid is gone, and 12th cranial nerve is also gone. Okay, coming to the lateral medullary syndrome. Lateral medullary or Wallenburg syndrome, I had just discussed in the image. Contralateral pain and temperature in the body, and same side face pain and temperature is gone because of its spinal nucleus, and also it's having equilibrium, it's gone because of spinocerebellar tracts. Okay, because of spinocerebellar tracts. This is the important thing which you have to remember in the medial medullary and lateral medullary Wallenberg syndrome. So the next we are going to discuss about the injury of the lower part of the medulla. When medulla lower part is damaged, because it has vasomotor and respiratory center, it's fatal, the person will die. Recently I had gone through in the hospital, and he came with the road traffic accident. Most of the road traffic accidents, who is not using helmets, they will die because of this. If there is any injury to the medulla oblongata, to the lower part, he will die because of this. Respiratory and vasomotor centers are gone, they will directly die on the spot. Okay, bulbar palsy. The next clinical anatomy we are going to discuss about the bulbar palsy. Weakness of the, it is nothing but weakness of the muscles of 7th to 9th cranial nerve. Palate, facial expression, pharynx, tongue, and larynx, these all are gone. It is lower motor neuron type of lesion. So lower motor neuron I had discussed about before. It's, you will be having muscle wasting, you will see hyporeflexia. Okay, these are the features regarding lower motor neuron. If you need a detailed video of this, I had just discussed in my video in the spinal cord. Okay, you will be having, so these are palate, facial expression, pharynx, tongue, and larynx. It's gone means what you will see. Difficult clinical features will be seen in this. He can't speak, difficulty in speaking, swallowing, and also facial expressions. He can't give his facial expressions. Okay. Next, we are going to discuss about the pseudo-bulbar paralysis of tongue, lips, pharynx, and palate. It is by pseudo name itself. It is telling pseudo. Okay, pseudo. Pseudo means something that's bulbar palsy is different. Pseudo bulbar palsy. Bulbar palsy direct because of muscle weakness, the nerve weakness to those muscles which they are causing. Pseudo bulbar palsy is nothing but it's because of vascular infraction. Okay, and syringomelia. I had discussed about the detail about the syringomelia in the spinal cord topic. Just to go through it, and increased intracranial pressure. So these are the causes of pseudobulbar palsy. Thank you, doctors.